Let's go ahead and get started. My name is Nicholas Franco, and welcome to the ACP Long COVID Interest Group. Today we have two fantastic guests from UCLA Health, and uh, I will also just remind folks that all of our recordings are on YouTube, so check my emails for links to the YouTube page or just search ACP Long COVID on YouTube. And with that, I'll turn it over to Dr. Chopra to introduce our guest for today.
Thank you, Nick. I'm so very excited today because our expert guests are also people I really look up to and I have learned a lot from. They are both really dynamic physician scientists. I'm so honored to introduce our leading voices in long COVID care in the US, Dr. Nisha Viswanathan and Dr. Daniel Puneky. Dr. Viswanathan is the director of the Long COVID program and co-director of the COVID ambulatory monitoring program at UCLA, where she's helping shape how we understand and manage this complex condition. Dr. Viswanathan is also a physician scientist, and she has done a lot of scholarly work in long COVID. She's also writing a very comprehensive paper on long COVID, and where we are working together to talk about different phenotypes of long COVID. Dr. Daniel Puneky is an internist and practices adult primary care at the UCLA Department of Medicine. He's also an HIV specialist. Dr. Puneky's clinical interests include care of the LGBTQ community, HIV primary care, and prevention. Welcome, Nisha and Daniel. Thank you so much for giving us time today.
Thank you so much for having us. I speak for both of us and say we're very excited to be here today. Nisha, I don't know if you wanted to say anything while I get the PowerPoint up and running.
Yeah, no, I think that, today really our talk is going to be on postural orthostatic tachycardia syndrome and dysautonomia. And this is one of the overlying syndromes in long COVID. And so while it may seem that we are moving into a space that doesn't seem to be directly involved in the care of the long COVID patient, we are finding in our clinical practice, this is something that we're seeing quite frequently. And as we all increasingly know, it'll be really important for primary care doctors to take on the heavy lift of caring for long COVID patients and therefore recognizing dysautonomia in our patients and learning some basic strategies on how to manage it can just have huge benefits for our patients.
Nisha, I want to interject a little bit, and I want to tell folks in primary care that as an internist, this has been a very challenging condition for me to not only diagnose dysautonomia and label it as POTS, but also to manage it. And it has been very difficult for me to navigate the different pharmaceutical and non-pharmaceutical strategies in dysautonomia. And I have attended several of Nisha's talks before, and I'm very excited. And I speak for all the primary care physicians on this talk. I think we will walk away with a lot of clinical pearls. So thank you very much, Nisha.
Great. I'll turn it over to Danielle now.
Thank you. I second actually a lot of what you just said. I think this was something of a challenge for us as well. And we had, early on, especially, we had good insight from some of our specialists, and we've continued to work with them closely and sort of built up all of our knowledge around that. So without further ado, so yes, we'll be speaking about POTS and dysautonomia in long COVID. Neither of us have any disclosures. And so our objectives today is to understand dysautonomia, to define POTS and its various subtypes, its risk factors and comorbidities. We'd like to recognize the relationship of POTS with long COVID, summarize the pathophysiology, and then develop and modify a non-pharmacologic and pharmacologic treatment plan for this complex condition. So what is POTS? Postural orthostatic tachycardia syndrome, or POTS, is a subset of the orthostatic intolerance syndromes, and these are in turn one type of dysautonomia. These are syndromes, of course, of dysfunction of the autonomic nervous system, and because of the myriad symptoms of various levels of severity that POTS can cause, For some patients, it's merely inconvenient, while for others, it can be anywhere from mildly to severely disabling. Primary symptoms of POTS are palpitations and lightheadedness that occur with upright positioning. That might be standing, or for many patients, it may even just be sitting. Symptoms typically improve or resolve with recumbent positioning. Syncope is relatively rare, but pre-syncope is actually quite common. There are many other associated symptoms beyond the most common. Those include, but are not limited to, fatigue, brain fog, blurred vision, nausea, dyspnea, headaches, shakiness, anxiety, among many others. And as you can imagine, of course, much of long COVID as well. So, epidemiology. POTS is important not just because it is potentially disabling, but because it is estimated to affect anywhere from 500,000 to 3 million individuals in the US alone. It is very common for there to be significant delays in diagnosis, with diagnosis taking on average 4.9 years, with a range of anywhere from 6 months to 6 years. And initial misdiagnosis is very, very common. The disease seems to predominantly affect white women of childbearing age. However, I encourage significant caution with this, so that the epidemiology of POTS is really not particularly well studied, and most of the available studies that we do have significant methodological flaws. The cross-sectional study that I have cited here is relatively recent. It's only from 2019, and it tells a story that's very similar to earlier studies. But the participants in this study were self-selected, self-reported, and this is all based off, the study was advertised on Dysautonomia International, which is a patient advocacy website. They did at least require that patients had been diagnosed with POTS by a physician, but the researchers didn't actually independently assess the participants themselves. So quite a few issues, right? And this is sort of one of the better, or these broader studies. Related conditions. So, there seems to be significant overlap with POTS and other conditions, most notably Ehlers-Danlos and the other hypermobility disorders. About a quarter of cases, we will see overlap there. Migraine headaches, also relatively common in about 40% of cases. Myalgic encephalomyelitis, chronic fatigue syndrome, or ME/CFS, a frequent comorbidity, and particularly common, of course, in our long COVID patients. But it's important to note that there can be significant overlap at baseline, just in the definitions of these conditions. So it's sometimes difficult to understand, where does the POTS begin and where does the ME/CFS end? The same can be said of mast cell disorders, where there's also significant overlap, and that includes idiopathic mast cell activation syndrome, or MCAS. There does seem to be an association with immunologic and rheumatologic conditions, and given the underlying pathology is dysautonomia, that really isn't surprising. But more basic science would be helpful to understand, what exactly is the common pathophysiology at play. So as we consider pathophysiology, I just want to start with some of the basics. I'm sure this is old news to most of you, but we're going to take a look at the autonomic nervous system, or ANS. This, of course, is separated into sympathetic, fight or flight, and the parasympathetic, rest and digest systems, which, of course, are in opposition and hopefully in balance with one another. The third branch, of course, is the enteric nervous system. Together, the ANS is responsible for controlling heart rate, blood pressure, respiration, digestion, urination, sweating, piloerection, pupillary reactivity, sexual function, all to support the needs of the body from moment to moment. And like other body systems, of course, it can become dysfunctional. Dysfunction can be generalized, meaning that it involves both sympathetic and parasympathetic nervous system, or restricted, either sympathetic or parasympathetic nervous system. It can be acute, subacute, or chronic in its development and its presentation. It can be continuous or paroxysmal in its timing, and it can occur in the central nervous system. It can occur peripherally, or you can have a mixed picture involving both. Dysautonomia can be broken down into several major syndromic groups. The primary and hereditary autonomic neuropathies, like pure autonomic failure, Parkinson's disease, These do not tend to be subtle. There's secondary autonomic neuropathies, which include things like diabetic neuropathy and small fiber neuropathy. These can sometimes be a little less obvious, at least initially. And we find in our practice that small fiber neuropathy in particular has significant overlap with other symptoms that we see in long COVID and may be one of the mechanisms at play. Finally, of course, we have the orthostatic intolerance syndromes, of which POTS is one. The orthostatic intolerance syndromes, of course, include orthostatic hypotension or a decrease in blood pressure withstanding of 20 millimeters of mercury or more in the systolic blood pressure, or 10 millimeters of mercury of the diastolic blood pressure. There's also neurally mediated syncope, or more commonly known as vasovagal syncope. That, of course, is a transient, self-limited loss of consciousness due to cerebral hyperperfusion from inappropriate bradycardia and reduced vascular tone, vagally mediated and an inappropriate baroreceptor response. I want to take a moment for inappropriate sinus tachycardia. That is defined as a symptomatic mean resting heart rate of 100 beats per minute while waking, and an average over 24-hour heart rate of 90 beats per minute or higher, without another primary cause. It should not be explained by other physiologic needs of the body at rest, and there can be very robust increases in heart rate even with minimal exertion. Rapid increases in heart rate of over 30 beats per minute in response to physiologic stress are not required for the diagnosis, but they are very common. And this is important because, as you can imagine, there's significant overlap with POTS. That in particular is significant because Aberdeen, which Dr. Viswanathan will talk about later, is indicated for the treatment of inappropriate sinus tachycardia while it is only used off-label in the treatment of POTS and can be helpful when working with insurance. So POTS. We're 14 slides in, we're finally coming to the subject of today's discussion. POTS is defined as a sustained symptomatic increase in heart rate of at least 30 beats per minute or more while moving from recumbent to standing. Symptoms must have been present for at least 3 to 6 months, and there must be an absence of orthostatic hypotension. As I mentioned previously, they should be symptomatic, lightheadedness, palpitations being the most common, but tremor, fatigue, general weakness, brain fog, blurred vision, exercise intolerance, all also very frequently present. Patients will often have standing heart rates that exceed 120 beats per minute. Symptoms are often worse in the morning, likely from insensible fluid losses overnight, or decreased overall sympathetic tone after sleeping. And again, pre-syncope is common, and while syncope is rare, it can sometimes occur. As with most conditions in medicine, we can of course break POTS down into its different subtypes: neurogenic, hyperadrenergic, and hypovolemic. So first, we will consider neurogenic POTS. This is typically caused by a peripheral autonomic neuropathy at the level of the small pseudomotor fibers. It's typically distal with a predominance in the lower extremities, although we may sometimes see involvement in the upper extremities, particularly the hands. This is a restricted dysautonomic type with involvement in sympathetic symptoms without parasympathetic, and this can lead to venous pooling in the legs and the splanchnic capillary beds, which is the result of reduced venoconstriction. Abnormal collagen and extracellular matrix in individuals with Ehlers-Danlos syndrome causes increased venous distension and pooling, and is likely why there's so much overlap or association with POTS. Upright with rising to standing or with upright sitting positioning, blood starts to pool, leading into to decreases in cerebral perfusion and also to lightheadedness. The body then compensates by increasing cardiac output, which causes tachycardia and palpitations. This is, of course, a high cardiac output state. Hyperadrenergic POTS. This is something you should expect if you notice that not only does the heart rate go up, but also the patients have an increase in their blood pressure. We need at least a 10 millimeter of mercury increase in systolic blood pressure. And this is a time where lab testing actually can be helpful, although it is challenging to obtain. So in normal healthy individuals, a supine plasma norepinephrine level is around 200 picograms per mil. And that is actually the same or very similar in individuals with POTS. But in healthy controls, when an individual stands for 10 minutes, they will have a doubling of their plasma norepinephrine to around 400, maybe up to 500 picograms per mil. In hyperadrenergic POTS, however, we see surges that are threefold or more in the norepinephrine levels. They should be at least 600 picograms per mil and are often well above 800 picograms per mil in the majority of cases. It can be really challenging to obtain these, to find a lab that will even do it for you. Patients need to be supine for at least 30 minutes before the first measurement. They need to then stand for 10 minutes before the second measurement. And while again, it can be really helpful to make the diagnosis, that's just very challenging to do in sort of modern systems and certainly modern labs. Studies show that as much as a third to a half, approximately, of POTS patients do have a hyperadrenergic subtype. And it's, there's likely abnormal catecholamine metabolism and or anti-adrenergic autoantibodies. These have both been demonstrated in hyperadrenergic POTS, and that may also be sort of a mechanistic link with long COVID, although the science is still a bit lacking. There's much more work to be done. Finally, hypovolemic POTS. So when you normally stand up against gravity, you're going to get about 500 to 800 mils of blood that are then displaced downwards towards the abdomen and the lower extremities. Normally, you're going to have a normal increase in cardiac output. You're going to have peripheral vasoconstriction. That's going to redirect blood back to the central circulation. And then, of course, with movement, rhythmic muscle contractions in the legs and in the abdomen are going to help move blood back towards the heart. However, in hypovolemic POTS, we see decreased levels of circulating renin and aldosterone. This reduces overall blood volume by lowering the retention of sodium and water. And with reduced volume, there's less venous return, and of course, a worsening reflex tachycardia to try to attempt to compensate for that lost cardiac output. Deconditioning, which is common in POTS because of hypervigilance to symptoms, exacerbates the problem further due to reductions in left ventricular size, reductions in stroke volumes, and further reductions in blood volume. So together, these things lead to a sort of downward spiral in which symptoms and attempts to avoid symptoms lead to decreased activity. That, of course, leads to decreased cardiovascular conditioning, and that further worsens the symptoms. And then, of course, the cycle starts over again. Dr. Viswanathan is going to talk a bit more about treatments soon, but this is part of why a gentle, appropriately graded, recumbent exercise program that does not significantly exacerbate symptoms really is a vital part of recovery in this condition. And of course, with long COVID patients or anyone with concurrent ME/CFS, this can be an even further challenge, right? Because of the post-exertional malaise, it becomes very challenging even then to manage not just the deconditioning, but the post-exertional malaise exacerbations. And so just taking a quick look at this chart, I think it's important to recognize that none of these POTS subtypes exist in independent silos. Most patients will have more than one type. Some patients will have all three. As you can see, they interweave with other at different points in their respective pathologies. But in the end, all of the factors eventually lead us down to tachycardia and altered cerebral perfusion. And that really is what causes the symptomatology of POTS. So just a few comments on the overlap with long COVID. So, as I mentioned before, there is significant overlap here. Dysautonomic syndromes are common in long COVID, particularly the orthostatic intolerance syndromes. Interestingly, I don't know if I've since seen the data to support it, but anecdotally with the hundreds of long COVID patients that we have each seen, I think now at this point, it seems like we're seeing more of the dysautonomia now than we did with some of the earlier strains of SARS-CoV-2. Again, I don't have specific data to support that, at least on my fingertips, but it definitely seems that way anecdotally. Initial orthostatic hypotension seems to be the most common, but studies have shown actually more than 30%. I've seen some that reported actually even up to 70% of patients meet criteria for POTS at some point in their long COVID journey. So why? Well, as we all know, there's still a lot of work to be done to determine what is the underlying cause. Is this a direct toxic effect of the virus to the central or the peripheral autonomic neurons or cardiomyocytes? Are there viral epitopes that trigger autoantibodies to catecholamine receptors or other neurotransmitters? Does SARS-CoV-2 lead to hypovolemia by triggering dysregulation of the renin-angiotensin-aldosterone pathway? Honestly, I don't know at this point what the underlying reason is. I'm not sure that anyone does quite yet. But I do know that the symptoms our patients experience are very real. And I know that there are smarter people out there who are working to figure this out. So there's a lot of work to be done, but I think it's fascinating, and I think there are a lot of things that we can do to help our patients symptomatically. And I'm going to turn it over to Nisha to talk about what those are.
Yeah, so next slide. So now we'll really focus on what do we do and what can we offer our patients when it comes to taking care of their long COVID and POTS when you see this combination in this patient population. So really the first step I would say is non-pharmacologic. And so as you can understand from the various mechanisms that Dr. Puneky was talking about, really I think there is a multifaceted approach to how can we manage their symptoms, not only the direct sequela, which I would say is the blood pressure, the heart rate, but also the other symptoms that we are seeing, such as their GI symptoms, the insomnia, the anxiety that we're seeing as well. So to start in the non-pharmacologic space, before we get into the medications themselves, I think education is the most important part of this. Understanding that you have this condition and how it is limiting in the way that you interact with the world is very important for these patients. For many of them, they may notice triggers, large meals, hot showers, positional changes. And so recognizing that they may need to make modifications in their lives, smaller, more frequent meals, avoiding, eating and then going and doing something incredibly exertional, those hot showers that are, for an hour long in the evening. And these can be ways of learning how to moderate themselves in life. In addition, though, before we get to medications, one of the big cruxes of therapy, and this is around really the hypovolemic and that neurogenic version of POTS, is really trying to increase volume. And so the volume can be increased really utilizing both salt and fluid. And so we tell patients, while here it states, 2 to 3 liters of fluid, you can actually take all the way up to 5, 6 liters of fluid in a day and up to 10 grams of salt in a day. And that's not an easy feat. Even for patients who keep high salt diets, we might be talking about eating 3 to 4 grams in a day. The average person probably is taking closer to 2 grams a day. This can just be a dramatic shift in eating habits, in addition to already maybe having to make those eating habit changes simply around having to take smaller frequent meals. In addition, salt tablets are something that can be really helpful here, but many patients notice that they develop nausea when they take this, so you may have to work with them in terms of electrolytes supplements as well. Some of the more popular ones, not that we're endorsing any, that have been spoken by many of our patients, especially on these forums, Reddit and Substack, they're talking more about LMNT is one of them, Potassium is another company, but really any of these electrolyte formulations. Gatorade and Powerade are very common, but we have to be careful. Many of them have sugar, and we're really trying to make sure that we don't cause new medical problems for patients in the midst of managing their POTS. For fluid, while we say 2 to 3 liters a day, if you can get to that 5 to 6 liters a day, it's really important. And then in addition to that, it's, these patients, we really know if they are able to do it if you see them in clinic, are they drinking water? Do they come with a water bottle? I found that's my biggest indicator of, are they actually probably getting enough fluid in a day, truthfully. In addition, ways to also drive up that venous return compression garments. This can come in, if your patients can't handle stockings or socks, then talking about compression socks or abdominal binders. Teaching them physical counter maneuvers. So this can be squatting or bearing down, which can literally help drive up the venous return if they're out in public and finding themselves to be in a pre-syncopal state. And lastly, I think, as Dr. Puneky spoke about, this idea of the graded recumbent exercise. So the one that we most commonly use is something called the Levine protocol. And this is actually something that was developed initially in the Children's Hospital of Pennsylvania, but effectively is this 12-week protocol where patients move from recumbent to standing progressively in the forms of their exercise. So a lot of times what we do is we send the referrals to physical therapy to really help our patients modulate these exercises, because it can be very hard, especially if they were not very physically active before they had POTS, to learn and understand what the protocol is requiring. But exercises that you can recommend, rowing machines, mat-based Pilates. These are all ways that patients can accomplish this at home. And lastly, I think is always just an important thing is that addressing polypharmacy is really important. I think if anything, the modern day has taught us is that people have more access to information than ever, but that may actually be at everyone's detriment, because it may require a matter of sussing out exactly what you're on. Maybe drug-drug interactions are causing worsening of your symptoms. So really just doing your due diligence, I think, as a provider is equally important. Next slide. So now we'll kind of break down our medications and how we look at them when we are addressing POTS. So this first set of medications will be those affecting volume. So how do we really drive that venous return? Let's say you have that patient, they've been trying to drink as much as possible. They're trying to get those electrolytes in. Maybe they can handle the compression wear, maybe they can't. But ultimately, they're finding it is not enough to help them get to the finish line. It's not enough to help them really feel better. So next slide. So really, I think understanding the mechanism of action here, this was actually from a paper that was a neurologic paper that was looking at this neurogenic form of POTS, but they did a very good job of showing us the various pathophysiologies in the body and where we can address our medications for this. So while you see here that prostaglandin, droxidopa, and midodrine are medications we would probably traditionally consider when we're talking about, cardiac syndromes, atomoxetine here as well. And its brand name is Strattera, and it's actually a medication that we use off-label to help with kind of an ADHD type picture. And as you can imagine, in this conversation, we've been talking about how POTS maybe doesn't present very neatly. Patients may not just say, I have palpitations or I have lightheadedness. They may actually say, I also have the brain fog and fatigue. And so this just goes to show that if we're looking at these medications working in these various pathophysiologies, that potentially also one of the mechanisms of action for POTS may be impacting these postganglionic sympathetic neurons and actually also driving the brain fog. And even if you manage the POTS cardiovascularly, you may need to do more to manage their other manifestations of POTS. And we'll get to some of those a bit later. Next slide. So the first drug I want to talk about is midodrine, which is a peripheral vasoconstrictor. So this is really good for driving that venous return, but there are some side effects associated with it. And I would say the one biggest issue I have when I actually in clinical practice prescribe this is that it is a BID to TID medication, so 2 to 3 times a day. Patients really struggle with having to take a medication that often, especially if they're already dealing with brain fog. They may just find themselves having issues with getting around to remembering all of these medications. But it really can help drive up that blood pressure when patients are consistent with it. And especially if, let's say, they can only take in so much fluid and salt, this can really prove as a beneficial ancillary. But I think it is important to know that because it's an alpha-1 agonist, we could have urinary issues. You can develop these paresthesias with the midodrine. And I found that for a lot of our older patients, I am seeing this supine hypertension. And so ultimately, we've either had to come down on the dose or really avoid that last dose of the day, because especially in the evening when they're going to be laying down a lot, it just may not be the right fit for them. Next slide. shifting our mechanisms, talking about something that's an acetylcholinesterase inhibitor that could drive up vagal tone is pyridostigmine. And this is a medication that I think that a lot of people may not feel comfortable, maybe even in the primary care space, getting around to prescribing to patients. But this, once again, by increasing that vagal tone, really can help drive that venous return. But at the same time, patients may experience a slew of other symptoms. And so I'm very hesitant in prescribing this, especially if we're talking about patients who already are having a lot of GI symptomatology. These patients with POTS will present a lot of times with ongoing diarrhea, and they already have some urinary issues. So pyridostigmine is one that I tend to hold off on initially prescribing, but it is something that is worth keeping in your toolbox, especially if you're thinking maybe there's a more neuropathic aspect to the POTS. We will talk about beta blockers here shortly, but I do want to say that it's contraindicated to do both at the same time. So if you are to do them, you need to do it very carefully. Next slide. Droxidopa is another medication that many providers are not that comfortable with. It is a norepinephrine precursor, but once again, it will drive up that vascular tone, which is what we're trying to get to. But very similar to our midodrine, we're probably dealing with some supine hypertension. It can interact with some of our sympathomimetics, MAOIs. So sometimes our older patients are on other medications, and so we have to be very careful with the droxidopa. I have seen the droxidopa be very effective clinically, but it is interesting because, as Dr. Puneky brought up earlier, sometimes patients have multiple versions of POTS. And so while this may help address their hypovolemic or neurogenic version of POTS, when they're also having the hyperadrenergic version of POTS, now it is just driving that version of POTS into overdrive. And it can be very hard because patients may be feeling better, but suddenly their blood pressure is just incredibly high. And it feels very counterintuitive to have a patient on both droxidopa and an antihypertensive at the same time. So I also advise a little bit of caution on starting this one. It's not my first line go-to, but these are all options. Next slide. So I will say that fludrocortisone is probably, in my clinical experience, one of the easiest ones for patients to start on. And so this is really, I think, my recommendation on a first line treatment, if it's not contraindicated for other reasons, as we'll discuss. It's a mineralocorticoid, meaning we increase volume. Therefore, we're both addressing the hypovolemic and actually even the neurogenic version of POTS fairly effectively with fludrocortisone. It's once daily dosing. It comes in 0.1 and 0.2 milligrams. And so patients find it very easy to remember to take and can be much more consistent with it. The biggest reason that I have patients come off of this is truly because of the edema and therefore the associated weight gain around this. But I have had patients use it and tell me, I felt so dramatically better. Even if we're coming off of this, I really do want to make sure whatever we go to is going to give me the same level of relief. It is unfortunate that when we do fludrocortisone, we probably do need to monitor blood work around this, especially the potassium. And you have to be really careful because if you have an older population that has heart disease, you have to be careful with that CHF as well. Next slide. But I think I just bring it up here with the fludrocortisone because it's just important to remember that it actually works here at our mineralocorticoid receptors, which are involved in the kidney, and that this actually can help drive those fluid shifts in our body. So I find fludrocortisone to be actually most effective for those patients who are doing a good job with the fluid, the salt, the compression wear, and that this is an excellent medication to augment their ongoing efforts. When you have patients who maybe just aren't able to get that fluid and salt in, sometimes then maybe leaning towards midodrine may be more effective because you have to have fluid to kind of drive up that venous return in fludrocortisone. Next slide. So now we're moving to our chronotropic agents. So these are really, our medications that are going to affect heart rate. And so moving to the next slide, with POTS, we have traditional POTS without that orthostatic hypotension or hypertension. We're really dealing with patients who are moving from seated or laying to standing and seeing that dramatic increase in heart rate. And with that, the symptoms really are dramatic with that increase. And so moving their heart rate down becomes really important, especially if you don't need to manage the blood pressure nearly as much with it. And so beta blockers are the crux of therapy here. That being said, as most people know, as I think most providers are fairly comfortable with beta blockers, obviously decreases in heart rate. And I would say most significantly, this patient population is dealing with fatigue. And so beta blockers have been known to worsen fatigue. So just keeping that in mind, that sometimes you'll start it will be effective at moving the heart rate down. But if you're seeing an increase in fatigue, it may not be the right fit for patients. You just have to be cautious, as we all know, with your calcium channel blockers, your digoxin, and if you are having the patient on it for an extended period of time, tapering becomes extremely important, as they can have a side effects in a withdrawal syndrome with beta blockers. So very important. I would say the number one reason, though, I end up stopping this for patients is it's either ineffective, it's not enough of the heart rate control, and it can potentially cause their blood pressure to drop. So even if they have some mild, maybe orthostatic hypotension, now it just gets exacerbated. So oftentimes it's not the best fit. Next slide. But sometimes we do need to do the trial of beta blockers to effectively do what I consider the gold standard in POTS, which is ivabradine. And ivabradine, which brand name Corlinor, is not a medication that I think many providers are very comfortable with. But ivabradine is a medication that actually just impacts the current, so that your electrical circulation in the heart, it causes a decrease in heart rate without affecting the blood pressure. It is incredibly effective in treating inappropriate sinus tachycardia, which is how I would recommend coding it if you are planning to use this medication, as it is FDA approved for that indication. And these patients are exhibiting an inappropriate sinus tachycardia. We just know that they also are meeting criteria for POTS. The big thing with ivabradine, though, is it can have dramatic and real drops in heart rate. And so understanding that is key, because knowing that a patient is not having any bradycardia is extremely important before you start ivabradine. So if you recognize that somebody has POTS, it is incredibly important to obtain some type of heart monitor, Holter, Zio patch, to rule out that they are having any kind of, for example, nocturnal bradycardia, which is very common. Patients sometimes have drops that are going all the way down into the 30s when they sleep, because we want to be very careful about giving them this medication, which could actually cause problems. That being said, if you're thinking about doing it and you see this patient that's on the borderline, it's always a good idea to engage with cardiology. But we have started the medication very comfortably for patients who, if we see that their heart rate really doesn't seem to have huge drops at nighttime and throughout the day, I think we can feel fairly comfortable in saying ivabradine will work for them. We start pretty low, I would say 2.5 milligrams twice a day, working your way up, and it goes up to a max of, I believe, 7.5 milligrams twice a day. And, really with this ivabradine, for patients, it's a twice daily dosing, so not something they always love, but it does bring down that heart rate as it goes up, and it can make patients feel dramatically better. It does have a CYP3A4 interaction, so always something to look out for there. But I will say one other thing that I've noticed clinically in practice, although it's not noted to be that frequent by the manufacturer, is constipation is fairly common here, which would make sense. If you're decreasing motility, you're probably decreasing, if you're decreasing motility of the heart, you're probably decreasing motility in your bowels as well. So some of these patients I've had to put on some stool softeners along the way. Next slide. So there was a really nice study that was done back in 2021. It was in the Journal of Cardiology, and it was basically looking at ivabradine norepinephrine levels in patients with POTS, which is specifically looking at this hyperadrenergic version of POTS, which is where you stand up and not only does the heart rate go up, but oftentimes the blood pressure may follow it. And they found that with the use of ivabradine, they were actually able over time, and I think the study went for about a month, to have a drop in that norepinephrine surge that we were seeing, and actually be able to have an improvement in not only the heart rate, but also with those surges decreasing symptomatology and quality of life, actually directly improved. So this actually goes to show that ivabradine, even though it's affecting the electrical current, is also probably having is really actually having a role in that earlier slide I showed you with the pathophysiology around, those norepinephrine surges and how they impact our fight and flight mechanism. Next slide. Oh wait, there should have been a slide for, oh, we should have had a slide on clonidine. So clonidine is one other medication that I want to briefly bring up here. So clonidine is actually a chronotropic medication, just many also know it as a blood pressure medication. And as we know in the literature, clonidine itself has actually been is not really the best blood pressure medication. I think as providers, we tend to move to other medications, and the guidelines typically do recommend other meds if we're just treating strictly hypertension. But if you see hyperadrenergic POTS, so if you're really seeing that, not only that increase in blood pressure, but also that increase in heart rate together, clonidine can be an effective option at managing both. And one of the beautiful things about clonidine is that it also will take down those surges of the norepinephrine. So it can play a big role here in hyperadrenergic POTS as well. So something worth considering. In my clinical experience, most people move to pills for clonidine, and I find that a lot of insurances would prefer individuals be on pills as they're significantly cheaper. But these patients, when the clonidine wears off, will start to have the surges of the norepinephrine again. So I've really found that giving a patient patches is the way you kind of keep it more stable throughout. But often I would say, once again, starting low, 0.1 milligram patches, and slowly working your way up, as patients can be really sensitive to these medications as well. So on that vein, talking about hyperadrenergic POTS, I think it's actually really important to know the role that hyperadrenergic POTS and mast cell activation play together. So Dr. Puneky mentioned earlier that mast cell activation is one of the overlaying syndromes with POTS. And this mast cell activation syndrome is one that I think many providers are also not very comfortable with. So I think recognizing it is also really incredibly important. But one of the things we realize now with this hyperadrenergic POTS, as we're having surges of the norepinephrine, your body is having a histaminergic release as a result. So it is literally, the norepinephrine is irritating the mast cells that are in the system, causing them to degranulate, and patients are having overwhelming symptoms. Oftentimes they'll describe, I was sitting fine, I stood up, and now I'm red, I'm hot, I've broken out in hives, or I'm having bronchospasm, difficulty breathing, and that is because of that mast cell activation and release. And so these patients, not only will they experience it, maybe you'll see it physically or you'll see breathing issues, but GI symptoms are very common. Diarrhea, especially with certain types of food, are really common in this mast cell population. They have histamine release with food, and so that can actually be one of the triggers as well. So as part of that, we talk about non-pharmacologic treatment for this. So that will be focusing on low histamine diets can be really effective, as well as trials of antihistamines. So Claritin, Zyrtec, really effective, and doing that in combination with your H2 blockers. So really famotidine is probably the crux of treatment there. But we have found that by managing the mast cell activation, oftentimes you can also then really manage the hyperadrenergic POTS, because patients, if they're having all of these symptoms every time they stand up, doesn't matter how much ivabradine and clonidine you give them, they're still going to have all this anxiety that comes with all of these other symptoms that are happening. So ultimately, that is one area to focus on. Mast cell stabilizers, Montelukast, Safirilukast, do play a role, and then really rarely we do have some patients who will need some of these monoclonal antibody types of medications, the immunologics. So we're talking about Xolair and Dupixent brand name medications. But I think recognition by the primary care provider is so important here, because it is hard to advocate for patients if you don't recognize what's going on. Next slide. So talking about that anxiety, some of the tactics we can use for these patients, paced breathing. There's an amazing app called the Awesome Breathing app that can really help patients kind of recognize when they have abnormal breathing rhythms and help them kind of regulate that when they have the surges of the norepinephrine or these changes in heart rate. Doing some CBT or biofeedback can be really effective here too. In addition, sometimes those beta blockers we're using for POTS management can be really effective here in anxieties, but propranolol, I would say, is actually probably the most effective of all. SSRIs are obviously great for anxiety. Benzos rarely, but I have seen panic disorders associated with these surges. And then I would always say this is in my back pocket, but buspirone can be really effective if patients just aren't working well with like an SSRI type of medication. But SSRIs may worsen some of their orthostatic symptoms. So just keep that in mind if you're going down that pathway. SNRIs can play a role, but you have to remember they do cause an increase in norepinephrine, so you have to be very careful with them. Next slide. GI-wise, these patients do have a lot of diarrhea and discomfort. So in addition to those small frequent meals, maybe considering a low histamine diet, really avoiding carb loading. I mean, not that they should avoid carbs, but just making sure you moderate how much you're eating, and then the fats, not having heavy fat meals that could maybe drive all the drive blood to your stomach in a dramatic way. Prokinetics, antiemetics, the regular medications we use around the GI will be really important here. But as I mentioned earlier with the pyridostigmine, be really careful if patients are having a lot of diarrhea. Next slide. Insomnia is one of the other symptoms that we see very commonly in this patient population. And if you can imagine walking around with surges of norepinephrine, it can be incredibly hard to rest and get good quality sleep. So, these patients a lot of times, in an attempt to not have just a massive amount of polypharmacy here, we say starting with sleep hygiene techniques, cognitive behavioral therapy for sleep has been very effective for my patients who are having insomnia with their POTS. But melatonin, or now the long-acting melatonin, Ramelteon, have been very effective. If we're looking at non-pharmaceutical versions, valerian root has also been very good at managing patients with their sleep. But especially if you're also having that anxiety, I will say that sometimes doxepin, which is an older medication, but treatment for anxiety and also sleep, can be really great for our patients who have insomnia. But just be careful, the clonidine, the beta blockers, we just don't want to add on too many medications that could be either too sedating or worsening of their fatigue. Next slide. So, based on today's talk, I think there was a lot of strategies that were discussed. Recognition is extremely important in being able to then lead to next steps in terms of treatment. And so, kind of as a summary of all the medications and all the management we talked about, is really step one, recognition. So I think that is getting your patient's blood pressures and heart rate, and being able to monitor that as a baseline. And then if you start medications or treatments, how are we changing? It will be very important that patients get very comfortable with being able to check their own heart rates and blood pressures when laying down and standing. In addition, being very judicious with how you use these medications. I would not recommend starting multiple medications at one time. Go slow, start low. We have to just be very careful with this population. Oftentimes they may not have been on other medications, so remembering that. Really doing a comprehensive med rec is important. And I think as part of that, looking at the supplements they're on, could there be any drug-drug interactions there? Patients are taking more things that we don't know about than ever. So just knowing that that could be playing a role. And then really, based on all their concomitant symptoms, could you with time consider adding on other therapies and treatments that could help them in managing their symptoms? So I think this should be kind of the provider's mini guide to how do we help address these patients. So thank you so much. And are there any questions?
Thank you so much, Nisha and Daniel, for this really amazing presentation and these really gorgeous slides. We love the slides. So my first question to you is, Nisha and Daniel, practically, what kind of abdominal binders should people use? Would a tight belt be okay, or should they go in for the full-fledged binders?
Go for it.
In my clinical experience, truthfully, I think we need something a little bit more than just a belt. I think we really need something compressing. And so I know this is one that has worked, is just the binder that female patients are prescribed after a C-section is actually probably the best. It is big, it's got straps, it's adjustable, and I found that my patients really find that one to be the most comfortable. But it's almost like a corset style binder.
And I think that's actually a really good point to bring up too, is because I've had conversations with a lot of patients about like using compression stockings, about using, binders, and they can, they're weird. They're not something that we wear normally, and so a lot of patients it takes time for them to acclimate. But I think it's really important to point out that compression stockings that go below they're not going to go to work if they go below the knee. Like they need to go up. The higher, the better. And it takes time to get, I think, patients to make that leap with you, but it is really important, and to make sure that they actually are using that, because they'll tell you they're using compression, but if you don't ask what type, then oftentimes we miss, like, oh, it's an ankle sock.
We'll say though, if they can do nothing else, the ankle sock is there, but sometimes it helps build that tolerance. So it can be a stepping stone, if you will.
And quickly, we just have a question in the chat if standard TED hose are okay, or if there's a millimeter mercury recommendation for compression.
So yes and no. If you talk to cardiologists, the more compression, the better. But it doesn't have to be medical grade, truthfully, in my experience. Whatever is the millimeter mercury you can handle is the best. But I think 15 to 30 is kind of the classic range that's been given in this area. But I think ultimately, if TED hose is all your patient can handle, then that may be all that you're able to successfully obtain for them. But the more they are, the higher you can go. And insurances will oftentimes pay for those higher millimeter mercury, but I'm hesitant to prescribe it initially simply because I want patients to just get in the habit of wearing something. And if I give them something that's very high, it may scare them off and then they may wear nothing. And so it's easier to say, hey, you've gotten used to it. Hey, let's go up a little bit. Let's see if we can do something a little tighter for you.
I mean, even sometimes starting with tight yoga pants can be a way to get people like on the right pathway. But yes, the higher you go, the better.
Talking about beta blockers, what are your go-to choices for beta blockers? I had a patient, I started him on propranolol, and he did not tolerate it because of hives. And he also has underlying MCAS. So what are your go-to choices for beta blockers? And can you use metoprolol or carvedilol in these patients?
I think you can. I like to start with propranolol because it's short acting. And if I can start with something that is shorter acting, particularly with long COVID patients, right? There's so many like sensitivities and intolerances to medications at baseline. And so I hate giving them something that's really long acting. And then all of a sudden, like now they're dealing with that, whatever reaction that they had for, day or days in some instances. So I usually will start with a short acting like propranolol. Of course, propranolol is going to affect, blood pressure more selective beta blockers. And so I actually will quickly convert to metoprolol if it's helping and if they're tolerating, because it's going to have less of an effect on the blood pressure. I will say I don't usually use carvedilol. If I'm looking at longer acting beta blockers, I'd rather give something that's once a day than twice a day, number one, but also going to have more alpha activity than metoprolol is. And so I'm always concerned there's going to be more of a dip in blood pressure. I think there's probably a space for patients who are more in the hyperadrenergic category, who, maybe are having a lot of elevated blood pressures. Maybe there is more room for carvedilol in that instance. But that's not usually the way that I'm thinking about it, unless maybe they've like failed things like clonidine and things that are more targeted at the hyperadrenergic process.
I actually had a quick question about blood pressure measurement. So we've heard from other speakers kind of about doing things like the NASA lean test and kind of these different ways of assessing these, or like sit-stand tests. And I'm just curious what your preferences are for in-clinic measurement versus at home, or in any tips you might have for kind of counseling patients if they are doing at-home readings.
So I would say the NASA lean was, a test that was developed by NASA to help identify actually, these subtle shifts, especially in orthostatic hypotension, that could be exhibited actually by astronauts as they were returning from space. So that being said, it is, it's lovely. You have the patient lay for 5 minutes, you do blood pressure, heart rate, you have them sit for a minute, and then you have them stand and lean up against a wall, and you check the heart rate and blood pressure you're supposed to do it every minute. Realistically, in a clinic, you probably get it every 2 minutes. And this way you can monitor heart rate and blood pressure progressively, especially if people have a delayed response or like a delayed surge of norepinephrine. You would have, you'll start to see that increase or decrease in blood pressure at the very end. That's great in a clinical space. If you have the capabilities, I would say many providers, that takes time, right? I just told you something that is going to take probably closer 15 to 20 minutes. That'll take staff out of circulation, and a provider may have moved on to the next room. So standard orthostatics is, kind of a more, what I like to say, rough and dirty way of dealing with it, or tilt table testing if you have that easily available. I will say we have struggled with that, as I know a lot of institutions have. But one thing that I have found with actually some degree of success is you can teach your patient how to do this so they can do their own NASA lean at home if they're engaged enough to help you make that diagnosis. And then actually I have patients, once we start them on medications, start doing versions of this at home. They start to know when the surge or when the change will be. And so they'll say, oh, I only need to stand for like 3 minutes, and we'll start to see number changes. Okay, then perhaps what we'll do is have you do a version where you lay down for a minute, you get your blood pressure, heart rate, you stand for 3 minutes, and you get your heart rate and blood pressure. And now we're able to make that comparison. How well is your medication working? So it can be tinkered with time. And I think engaging your patients becomes so important. They end up becoming their own biggest advocates. And so if you can get them engaged in that management, especially focusing on those numbers, it can really help not only them in recognizing where those shifts happen, but also you in terms of helping you with your management.
Great, thanks.
Looks like we did answer all of the questions in the chat. Thank you so much, Daniel and Nisha, for this really engaging and so informative, such an informative session. It's been really enlightening for me. I learned so much, and it gives me some framework and comfort to manage these patients with these very, very difficult and challenging symptoms. Thank you very much. I learned a lot, and I know that everyone in the audience learned a lot today. Thank you very much for your time and for sharing your expertise with us.
Thank you so much for having us.
Thank you so much. Yeah, it's been a pleasure.